Good morning.
Please. Good morning, everybody. Today we will discuss about hospital-acquired pneumonia and ventilator-associated pneumonia. I am Dr. Gauranga Shikhar, DRMD first year, critical care medicine. So to introduce, hospital-acquired pneumonia or nosocomial pneumonia and ventilator-associated pneumonia are important causes of morbidity and mortality, despite improved preventions, antimicrobial therapy and supportive care. The incidence of nosocomial pneumonia is between 5 to 10 per 1000 hospital admission, and the incidence of death is estimated to be 9 to 27% of patients undergoing mechanical ventilation for more than 48 hours. So first, we should discuss about the different terminology used in these sections. So those are nosocomial pneumonia. It may be defined as an acute infection of pulmonary parenchyma acquired in hospital setting, which encompasses hospital-acquired pneumonia and ventilator-associated pneumonia. The hospital-acquired pneumonia is defined as the pneumonia acquired equal to or more than 48 hours after hospital admission, include both HAP and VAP. And the ventilator-associated pneumonia, that is VAP, is defined as the pneumonia acquired more than or equal to 48 hours after the endotracheal intubation. Now there was another term, that is healthcare associated pneumonia. Nowadays we don't use this term, which refers to the pneumonia acquired in healthcare facilities, nursing homes, hemodialysis centers, or after recent hospitalizations. The logic behind the removal of the healthcare associated pneumonia is that actually by using this we were overusing the antibiotics, so to constrict the use of antibiotics we have done these things. Now another few terminologies like as per etiology, the atypical pneumonia, the pneumonia caused by atypical bacterial pathogens including Legionella species, Mycoplasma pneumoniae, Chlamydia, Chlamydia psittaci and Coxiella burnetii. Though the term whether it should be atypical or not is debated. And the aspiration pneumonia, it is an adverse pulmonary consequences due to entry of gastric or oropharyngeal fluids, which may contain bacteria and of low pH or exogenous substances like ingested food particles or liquids, mineral oil, salt or fish waters into the lower airways, fresh waters. And chemical pneumonitis, that is an aspiration of substances in the acidic gastric fluid that causes an inflammatory reaction in the lower airways independent of bacterial infection. And bacterial aspiration pneumonia is an active infection caused by accumulation of large amount of bacteria into the lungs via orogastric contents. Now there are different types of classifications, so not very popular nowadays. There is an early onset and late onset VAP. What it said that early onset VAP that occurred within 5 days of mechanical ventilations, and late onset VAP that occurred after 5 days of ventilations. And the concept was actually what it was thought that the difference initially thought was clinically significant, because they said that in early VAP that occurred within 5 days of mechanical ventilation, that occurs commonly due to the pathogens likely means like CAP, that is community acquired pneumonia. And in late onset VAP, the pathogens are mostly in-air pathogens. So that was the concept. But currently there is increasing report of lack of differences in the microbiology across both groups. So the patients in contact with healthcare environment or who are immunocompromised are prone for in-air infections irrespective of onset of VAP. Now another thing is there, that is a ventilator associated events. So it is used means for VAP surveillance, means when the epidemiologists use the terms, they use as ventilator associated events to generalize all those things. Actually means by using the clinical and radiological criteria, we often overdiagnose or underdiagnose VAP. So to means correct these things, the CDC put forward epidemiological definitions called the ventilator associated events, and it started in the year 2011, and in 2019 the latest changes in terminology and clarifications came. And to be assessed for ventilator associated events, patients should be ventilated for a minimum of 4 calendar days with at least 2 days of clinical stability. Though one thing you should keep in mind that these are only the surveillance definitions and are not supposed to be used for treatment decisions. So what are these terminologies? So these are ventilator associated events. These are also there is ventilator associated condition, that is VAC, infection related ventilator associated complications, that is IVAC, and possible VAC. So how we can classify? Here we are telling that we have told that patient should be ventilated for more than 4 calendar days. So there they are telling there will be the primary initial stability or improvement followed by sustained period of forcing oxygenations. So suppose means 4 days of ventilations, initial 2 days the patients have some improvement and followed by forcing oxygenation, then we should call it a ventilator associated conditions. Now we have to define what is the forcing oxygenation when we will say. So here you can see that forcing oxygenation will be told as the increased daily minimum FiO2 requirement more than 20% over the minimum daily FiO2 of the first day in the baseline period sustained for more than equals to 2 days, and the peak requirement increase in the daily peak requirement more than equals to 3 cm/h2 over the daily minimum peak requirement, and it will be sustained for more than equals to 2 days. So then we will call it as ventilator associated events. Now the IVAC, that is infection related ventilator associated complications. So there should be the general evidence of infections and inflammations. So which are those? Those are, there should be a temperature of more than 38 or less than 36 degree, or white blood cell counts more than equals to 12,000 or less than equal to 4,000, and a new microbial agents that is started and is continued for more than equals to 4 calendar days. Now the possible VAP. So when we should tell there is possible VAP, there should be microbiological confirmations of that. How we could do that? There are 3 criteria, at least one should be filled up. Now criteria 1, when actually means there is semi-qualitative thresholds, means positive culture of one of these following specimens meeting quantitative and semi-quantitative thresholds as outlined in the protocol without requirement of purulent respiratory secretions. So if the patient doesn't have that purulent secretions, we can use this criteria if the pulmonary forming unit we are seeing, if it is in endotracheal aspirate, the CFU is more than equals to 10 to the power 5 CFU per ml, it will be suggestive. For BAL, it is more than equals to 10 to the power 4 pulmonary forming unit per ml. For lung tissue, more than equals to 10 to the power 4. And for protected specimen brush, it is more than equals to 10 to the power 3 CFU per ml. So it will suggest possible VAP. If there is presence of purulent secretions, then it is telling that means how you will define a purulent secretion, that is a fact. That is, it contains more than equals to 25 of neutrophils and less than equals to 10 squamous cell epithelial cells per low power field, and organisms identified from one of the following specimens. We say that this number of pulmonary forming unit is not required, only presence of bacteria will suffice. If it is a purulent secretions, and the specimens may be taken from sputum, endotracheal aspirate, BAL, lung tissue, and protected specimen dust. And another criteria is there, that is criteria 3. So organisms may be identified from pleural fluid. Lung histopathology may show lung abscess, evidence of lung parenchymal infections by fungi, evidence of infections with the viral pathogens listed below, diagnostic test for Legionella species, diagnostic test on respiratory secretions for influenza virus, respiratory syncytial virus, adenovirus, parainfluenza virus. So if any one of these criteria is present, we will say that it is a possible VAP. Now, is there any score? Means the probable VAP should not possible or probable. You take intake data. Possible or probable. So, is there any score? Means, usually we use a clinical and radiological criteria to define VAP or to diagnose VAP. But a consensus on the diagnosis of VAP in ICU is difficult to attain in view of numerous confounders such as ventilator-associated tracheobronchitis, non-specific findings in chest X-ray. So it was suggested that an integrated clinical radiological approach with the help of CT score, that is clinical pulmonary dissection score, could help to identify the patients who have VAP. Now total score ranging from 0 to 12, a score greater than or equal to 6 has good correlation with the diagnosis of VAP. But the current IDSC guidelines suggest the use of clinical criteria than CTs for initiating and stopping of antibiotics. So we don't use this nowadays so popularly. Now these are the points for CT score calculation, that is tracheal secretions, rare, abundant plus purulent, chest X-ray infiltrates, no infiltrated, diffuse, localized, temperature, leukocyte counts, PaO to pyruvate ratio, presence of ARDS and microbiology. So with this criteria, we get 0 to 12 numbers. So if it is more than 6, that is more likely.
Chest X-ray infiltrate diffuse is 1, localized is 2.
But you see, if you got a pneumonia, there's more likely to be any unilateral sort of a thing. যদি bilateral হয়, other pathologies এর চান্সটা অনেকটা বেড়ে যায়. So that is it. আমরা যখন এক্সরে দেখি আমরা বলতে দুদিকে opacity আছে, more likely to be pulmonary edema or something like that. একদিকে আছে more likely. So that's it.
So now means one thing, that is a radiological differentials for a patch. So if we get a patch on radiology, it may be due to any of these reasons like consolidations or pneumonia, collapse, pulmonary embolisms, pulmonary edema, re-expansion pulmonary edema, pleural effusions, parenchymal fibrosis, bronchiolitis obliterans, organizing pneumonia, pulmonary hemorrhage, eosinophilic pneumonia, drug-induced parenchymal disease. So for these reasons, to diagnose that is difficult. Now, in very few sentences, I got the antimicrobial resistance. So the United States Center of Disease Control and Prevention and the European Center for Disease Prevention and Control have developed a standard terminology for antimicrobial resistance for gram-negative bacilli, which are important also have and have. So MDR, that is multi-drug resistance, referred to acquired non-susceptibility to at least one agent in 3 different microbial classes. That is XDR, that is extensively drug resistant, refers to non-susceptibility to at least one agent in all but 2 antimicrobial classes. And PDR, that is pan drug resistance, refers to susceptibility to all antimicrobial agents that can be used for treatment. Now the management portions. So how we will treat? So before treatment, it should be remembered that it should be prevented. Means VAP can be prevented, so we should give every effort if we can prevent VAP. So what are the preventive measures? So these are the summary of recommendations for preventing VAP in adults for SHA and IDSA. So there are few high quality evidences there, moderate quality evidences there. These are the basic practice you should follow, and these things are recommended, like the use of non-invasive positive pressure ventilations in selected patients populations. So if ventilation is not that much required, we should try with NIV, that is a high recommendations. Manage patients without sedations whenever possible. Interrupt sedation daily, so sedation holidays, that is important. Assess readiness to extubate daily. Perform spontaneous breathing trial with sedatives turned off. High quality evidence. Facilitated early mobility. Utilize endotracheal tube with subglottic secretion drainage boards for patients expected to require greater than 48 and 72 hours of mechanical ventilations. That is a moderate evidence. And chances of ventilator circuit only if visibly soiled or malfunctioning, that is a high quality evidence. And elevate the head of bed 30 to 45 degrees, that is a low quality evidence. And special approaches we can do, though it is not commonly recommended, not as a daily recommendations, but we can do this, like selective oral, which we do it, that is selective oral or digestive decontamination. This This is of high evidence. Regular oral care with low laxity, moderate quality evidence. Prophylactic probiotics, that is of moderate evidence, and these are of low quality evidence, like automated control endotracheal tube, cuff pressure, saline instillation before tracheal suctioning, mechanical tooth brushings, and generally not recommended, but these are of importance, like silver coated endotracheal tubes, that is a moderate quality evidence, kinetic beds, prone positionings, stress ulcer prophylaxis, these are of moderate quality evidence, early tracheostomy is of high quality evidence, but not generally recommended, monitoring residual gastric volumes, early parenteral nutrition is also moderate quality evidence. And no recommendations, there is no recommendations in closed or inline endotracheal suctioning. This is of moderate quality evidence. Now, empiric therapy. So, obviously, when we will suspect that empiric therapy should be started, still we get the culture report. So, if we get the culture report, the definitive treatment will be modified according to that. But before that, we should start the empiric therapy without any delay. So, the empiric therapy for HAP and VAP should include agents with activity against Staph aureus, Pseudomonas aeruginosa, and other gram-negative bacilli. The choice of a specimen for empiric therapy should be based upon the knowledge of the prevailing pathogens and susceptibility patterns within the patient's healthcare settings, as well as the patient's individual risk factors for multi-drug resistance, and including their prior microbiology data. And a good quality downstream can also be useful for guiding the choice of initial therapy. The recommendations below are generally in keeping with the 2016 Infectious Disease Society of America and Infectious American Thoracic Society guidelines on the management of that. And we also highlight the recent drugs or new drugs that has come after 2016 in brief. Now, what are the approaches to therapy? So, once HAP or VAP is suspected clinically, diagnostic specimens should be obtained as soon as possible in all patients, and antibacterial therapy started as soon as possible in patients with signs of septic shock or rapidly progressive organ dysfunctions. Delaying treatment and failing to give a regimen with activity against the positive pathogens are both associated with higher mortality rates in patients with HAP. However, broader regimens and longer treatment course increase the risk of adverse drug effects, serious infections, and antimicrobial resistance. So also you should keep these things in mind. And establishing the diagnosis of HAP and VAP can be difficult, especially for hospitalized patients in whom clinical, radiologic, and microbiologic findings can be due to numerous etiologies besides pneumonia. If the diagnosis of HAP and VAP is uncertain and the patient is not in sepsis or septic shock, then it appears to be safe and potentially beneficial to gather more data and await culture results before treating. Empiric treatment choices should be based on the local distributions of pathogens causing HAP and VAP and their antimicrobial susceptibility pattern. And one important thing is that all hospitals should regularly create and disseminate a local antibiogram, ideally ones that are specific to their different units. An additional consideration includes potential toxicities, potential drug interactions, cost, availability, and clinicians' familiarity with the medications. Once microbiology results are available, therapy should be narrowed based upon the susceptibility pattern of the pathogens identified and the potential toxicities of the regimens. Reassessing a patient's status 48 to 72 hours after the initiations of therapy with considerations of discontinuing antibiotics, of narrowing the regimens, that is de-escalating therapy, based upon the appropriate culture reports. So we should always think whether we can de-escalate the antibiotics or not. Now first we should know the risk factors. It will be important to select the antibiotics. So risk factors for MDR pathogens, when we should suspect. So if there is history of IV antibiotic use within the previous 90 days, septic shock at the time of VAP, ERDS preceding VAP, more than 5 days of hospitalizations prior to occurrence of VAP, and acute renal replacement therapy prior to VAP. So if these are present, any one of these, we should suspect there may occur of MDR pathogens. And the risk factors of MDR, Pseudomonas and other gram-negative bacilli are treatment in an ICU which is more than 10% of gram-negative isolates are resistant to agents being considered for monotherapy. Treatment in an ICU which local antimicrobial susceptibility rates are not known, and colonizations or prior isolations of MDR, Pseudomonas or other gram-negative bacilli. So this percentage we can get from the hospital antimyograms or tyrosine. And the risk factors of MRSA, that is a treatment in units in which more than 10 to 20% of staph aureus isolates are methicillin resistant. Treatment in a unit which the prevalence of MRSA is not known, and colonizations with or prior isolations of MRSA. So these are the risk factors. So how we will select the empiric antimicrobial therapy? So as per IDSA and ATS. These are the flowcharts. So first we will see, it is the simplest form. First we are seeing whether there is risk factors for MDR pathogens or not. The 5 criteria we have told. So that is a IV antibiotics 90 days, septic shock, ERDS, more than 5 days of hospitalization, acute renal replacement therapy. So we are going with the simpler things. If all these things are not present, that is all these things are absent, then we will go for the risk factors for gram-negative pathogens. So what I have already told, that is more than 10% of gram-negative bacilli that are resistant to an agent is being considered for immunotherapy, and the prevalence factor, if not known, also within this group. So first we have checked the MDR susceptibility, then we have checked whether there is risk factors for MDR for gram-negative bacilli. If it is absent, then we will check for the presence of risk factors for MRSA, that is methicillin resistant staphylococcus. So if everything is absent, so if it is a good case actually, everything is absent, then we can go with a monotherapy with a good broad spectrum coverage. Forget the drugs, that is piperacillin tazobactam, 4.5 gram IV QDS, cefepime 2 gram IV QDS, and levofloxacin 750 mg IV every 24 hours. If there is no risk factors for gram-negative pathogens, but there is risk factors for MRSA pathogens, then we should also cover antibiotics that covers the MRSA pathogens. So here, for gram-negative pathogens, we may use piperacillin tazobactam, cefepime, ceftazidime, levofloxacin, ciprofloxacin, aztreonam is also there, and for MRSA, we can use vancomycin or linezolid, and for vancomycin, the dose will be, loading dose will be 20 to 35%, 35 milligram per kg, the initial bolus, and then actually it should be ideally assessed by the nomograms by using the blood concentrations, and typically the dose is 15 to 20 milligram per kg every 8 to 12 hours, and it should be guided by the adjusted means area under curve and the MIC value. There is a nomograms for vancomycin. With this we can calculate the exact dose. And for linezolid, it is usually 600 milligram IV, 12 hourly. Now the flowchart is little different. Actually, here means the risk factors of gram-negative bacteria we have assessed. The previous charts there was no risk factor of gram-negative bacilli. Here the risk factor of gram-negative bacilli is present. That is yes. So if there is risk factor for gram-negative bacilli, then we will assess the risk factor for MRSA. So if MRSA is absent but the risk factor of gram-negative bacilli is present, we should consider the dual antibiotics for gram-negative coverage. So the first line antibiotics will be piperacillin tazobactam, cefepime, imipenem or meropenem, and plus one of the following, the second line drugs will be preferably aminoglycosides like amikacin 15 to 20 milligram per kg IV daily, or gentamicin or tobramycin, but we should consider the nephrotoxicity, ototoxicity part of this aminoglycosides alongside. And also you may use levofloxacin, ciprofloxacin, levo the dose 750 mg IV every 24 hours or cipro 400 mg IV every 8 hours, and aztreonam is also there, but means if we want to prefer one, aminoglycosides is more preferred because it is highly susceptible for gram-negative in severe gram-negative infections. And if there is also simultaneously there is risk factor for MRSA, then along with dual negative antibiotic coverage, we use the antibiotics for means MRSA. So that is fast line drug similar to here. Little changes are there. Means lipzocefidine, ceftazidime. All these things are pseudomonas coverage, ibuprofen, meropenem or aztreonam. Plus one of the following, that is aminoglycosides or ciprofloxacin or monoactin, that is aztreonam. Plus one of the following, we may use vancomycin or linezolid. And if one thinks if there is means risk factors for India, we may directly go into these flowcharts, like we should use dual antibiotics for gram-negative coverage plus one MRSA agent. Now the facts, few facts about these antibiotics. Like among these agents, actually what I have said that we generally prefer a pibzo or cefepime because they are more likely to have activity against gram-negative bacilli than levofloxacin. If we want to use as a monotherapy, we prefer pibzo or cefepime. IDS-ATS guidelines also include imipenem or meropenem as an options, but we generally reserve these agents for patients with high likelihood of infections with ESBL producing gram-negative bacilli. And one thing is that in favor prolonged infusions, I will tell in later, of broad spectrum beta-lactams for empiric and targeted therapy of gram-negative bacilli in critical patients. And one thing is that we generally prefer pibzo-cefepime, ceftazidime because they are likely to have actually in compared to fluoroquinolone and aztreonams, we usually prefer pibzo-cefepime or ceftazidime because they are more likely to have activity against gram-negative bacilli. And one thing that is the combinations of vancomycin and pibzo has been associated with acute TB injury. We should keep this thing in mind. So if we use vancomycin for MRSA, we should use a different group of antibiotics. And if we use piperacillin tazobactam, preferred we should use linezolid for MRSA. That is the common sense. And the vancomycin loading dose is based on actual body weights. The dose is rounded to the nearest 250 milligram increment and not exceeding 300 milligram per day. Within this range, not 300 milligrams single dose, within this range we use the higher dose for critically ill patients. And for anti-pseudomonal coverage, fluoroquinolones, we recommend either an anti-pseudomonal fluoroquinolones or an aminoglycosides for second agents of gram-negative bacilli, but we generally prefer an aminoglycosides. What I was telling is if there is no concern of Legionella-like infections, we generally prefer aminoglycosides. And the IDS-ATS guidelines include polymyxin B and colistin as an option for the second agents for gram-negative bacilli. But polymyxins are used rarely given their significant nephrotoxicity and should be avoided if alternative agents with adequate activity against gram-negative bacilli are available. And also the IDS-ATS guidelines include the polymyxin B and colistin as options for the second agents. Polymyxins are used rarely. We typically discontinue the aminoglycosides after 1 or 2 days, especially in patients who have improved clinically and in whom the pathogen is susceptible to beta-lactam. So if the culture report is in our hand, so we should think about de-escalating the aminoglycoside if we can do. And in the absence of other options, it is acceptable to use aztreonam as a second agent for the gram-negative bacilli with other beta-lactam because it has different target within the bacterial cell wall. We use aztreonam infrequently since the rate of resistance among the gram-negative bacilli are typically higher than the other beta-lactam options. Now I will tailor the therapy. For patients in whom the pathogens have been identified, the empiric regimen should be tailored to the pathogen susceptibility pattern. The patients who are clinically improving, who do not have identified pathogens, empiric treatments for staph aureus or India gram-negative bacilli can be discontinued. if these organisms have not grown in cultures from high quality sputum specimens within 48 to 72 hours. So patients who have not improved within 72 hours of starting empiric antibiotics should be evaluated for complications, other side of infections, and alternative diagnosis. If the diagnosis of pneumonia appears certain and there is no evidence of a pyogenic complication that requires drainage, empyema lung abscess, no evidence of untreated infections elsewhere in the body, and the patients have risk factors of drug-resistant pathogens, prolonged hospitalization, recent exposure to multiple antibiotics, additional diagnostic pulmonary culture should be obtained, and the empiric regimens can be expanded to cover additional resistance organisms. And usual depressions, so we treat most patients of Ebola for 7 days in agreement with the 2016 5-day guidelines. 7 days appears to be as effective as longer durations in most circumstances and may reduce the emergence of resistant organisms. For selected patients with severe illness, bacteremia, metastatic infections, slow response to therapy, immunocompromised, and pyogenic complications such as empyema or lung abscess, the durations of therapy should be individualized and courses longer than 7 days may be warranted. And monitoring serial procalcitonin levels can help the decision to discontinue antibiotics, while the optional approach to the use of procalcitonin in patients with HAP and HAP has been determined a low or declining procalcitonin level, like less than 0.25 nanogram per ml or more than 80% decrease from peak in a patient who has clinically responded to antibiotics provides an additional reassurance that antibiotics can be safely stopped. Now, the specific antimicrobial considerations and the newer agents. So, the situations where allergy to penicillins or cephalosporin comes. For patients who are allergic to penicillins, the type and severity of the reaction should be assessed. The great majority of patients who are allergic to penicillins by skin test can still get the cephalosporins, especially third generation cephalosporins, third generations or carbapenems. So if there is mild reactions, that is not an IG mediated reactions, we can use the cephalosporin or carbapenem group. And we usually use the term that is simple graded challenge, where we give the 1/10th dose followed by a 1 hour period of observation. If no symptom, give the full dose followed by another hour of observation. If skin test is positive or there is a significant concern to warrant the avoidance of cephalosporin or carbapenem, then aztreonam is recommended. But one thing is that patients with a history of allergic reactions to cephalosporin may be treated with aztreonam with the possible exceptions of allergic reactions to cephalosporin. So if the patients have allergy to cephalosporin, we may use aztreonam, but there is a cross reaction between the ceftazidime or aztreonam. So if the patient has allergy to ceftazidime, we can't use aztreonam, and vice versa. It is important to note that aztreonam doesn't provide activity against gram-positive bacilli that much like Staph aureus. Also, ceftazidime has less activity against MSSA, methicillin-susceptible Staph aureus, than other beta-lactam. It suggested above and that when one of these agents is used for empiric therapy, and additional agents with activity against Staph aureus like linezolid or vancomycin should be used. Now, regarding prolonged infusions. So, beta-lactam antibiotics demonstrated time-dependent effect on bacterial eradication. So, the period of time, the drug concentrations will be above the MIC level, it will active. So with this concept, it came that prolonged infusions achieve pharmacodynamic efficacy targets defined for beta-lactam antibiotics more effectively than short infusions. So prolonged infusions may therefore improve the microbiology and clinical cure, especially for pathogens with higher MIC. We favor prolonged infusions for beta-lactam for empiric and targeted therapy of gram-negative bacilli in critically patients with HAP and HAP, as well as for patients with HAP and HAP caused by gram-negative bacilli that are elevated but susceptible MIC to the chosen agent. Now, actually, these are the time period infusion times. Like for Pibzo, it is around 4 hours. These are different dosings, which is modified according to the creatinine clearance. So in general, it is around 4 hours of infusion. For cefepime, it is around 3 to 4 hours. Imipenem 3 hours, meropenem 3 hours. So it is around 3 to 4 hours infusion we usually give. Now regarding the aerosolized antibiotics, we give as aerosol. That is, aerosol is colistin, polymyxins, or aminoglycosides can be used at adjunctive therapy. Aerosolizations may increase the antibiotic concentrations at the site of infections and may be particularly useful for treatment of organisms that have high MIC to systemic antimicrobial agents. So in the meta-analysis of 13 randomized trial, that adding of aerosols amikacin to IV antibiotics for gram-negative pneumonia versus treating with IV antibiotics alone was associated with higher rate of clinical cure in unblinded studies. So in blinded studies, the result was not that much good. However, adjunctive aerosolized amikacin was associated with more bronchospasm, sometimes with hypoxemia. Another meta-analysis analyzes the potential impact of adding aerosolized colistin to intravenous colistins, and the investigators reported the better clinical outcomes and microbiologic eradication rates associated with aerosolized colistin. And methicillin resistant staph aureus, if we consider, if MRSA is frequent nosocomial pathogens in the institutes for more than 20%, linezolid vancomycin should be included as per IDSA guidelines. Because clinical outcomes are similar for linezolid and vancomycin, we select between these agents based on other factors like renal functions, monitoring convenience, potential blood interactions, blood cell counts, and quality of intravenous access. The newer agents like telavancin and tedizolids are alternative agents which neither linezolids nor vancomycin can be used. So regarding telavancin, the dose is 10 mg per kg IV every 24 hours. Is an alternative agent, so when neither of these two, that is linezolids or vancomycin used, but there are several boxed warnings that must be considered before choosing it. Box warning includes the information about the risk of acute kidney injury, increased mortality in patients with pre-existing acute renal failure. And tedizolid that is associated with a lower clinical cure rates compared with the linezolid in a randomized trial, though mortality rate was similar. And if we linezolid versus vancomycins, if we consider several trials have compared to linezolid vancomycins, and the results are mostly similar. Few trials preference have given for linezolid. That may be actually several trials including this meta-analysis use the lower doses that is recommended now by the IDSA. So that may be due to the reasons linezolid get preferred. Another thing is that the vancomycin failure might also be related to the vancomycin minimum inhibitory concentrations. That is, pharmacokinetic and pharmacodynamic analysis suggests that the lung vancomycin area under the time concentration curve to MIC value is more than 400. So that may be difficult to achieve for an isolate if MIC is more than 1. So some clinicians nonetheless favor using an alternative to vancomycins for treatment of pneumonia if a MRSA strain with MIC value is more than 2 microgram per ml. So if it is more than 2, better to avoid vancomycin. And there has been interest to other agents. So what are the other agents we can use in MRSA? So these are now no recommendations is still now officially. Those are daptomycins, cannot be used to treat pneumonia because it is inactivated by surfactant and doesn't achieve adequate concentrations in the respiratory tract. One is ceftaroline. It is a broad spectrum cephalosporin with activity against MRSA. It has been approved by the FDA for community acquired pneumonia, but not for CAP caused by MRSA. Tigecycline is a broad spectrum antibiotics with activity against MRSA. It has been approved by FDA for skin and skin structure infections and intra-abdominal infections caused by MRSA. It has also been approved for CAP, but not for CAP caused by MRSA. So tigecycline is not recommended till now. Ceftobiprole is a broad spectrum cephalosporin with activity against a broad range of gram-positive bacteria including MRSA and penicillin and ceftriaxone resistant pneumococci as well as gram-negative bacteria, it has not been approved by the FDA, but it has been approved in Europe and Canada for treatment of HAV and CAF, but not for VAV. Now for gram-negative pathogens like ESBL producing enterobacteriaceae, we generally select a carbapenem like imipenem, artapenem or meropenem as a part of our empiric therapy. Among carbapenems, dolipenem should not be used for the treatment of VAV when other carbapenems are available. The novel agents that are ceftazidime avibactam and ceftolazone tazobactam are additional options that are acting against many ESBL. Now the carbapenems producing gram-negative bacilli, the novel agent ceftazidime avibactam is active against many carbapenems producing strains. Alternatively, combinations of regimens are often given, often including a polymyxin, that is polystyrene or polymyxin B. For those with an isolate that is susceptible only to polymyxin, that is polystyrene or polymyxin B, one of these agents should be given intravenously together with inhaled polystyrene. The combinations of inhaled and intravenous polystyrene is used because IV polystyrene does not achieve high concentrations in the lung. And Acinetobacter pneumoniae patients will have or have caused by Acinetobacter, a carbapenem or an ampicillin sulfactam should be used if isolate is susceptible. If isolate is susceptible only to polymyxin, like polystyrene or polymyxin, like previous, one of these agents should be given intravenously together with inhaled polystyrene, since intravenous polystyrene gives a low lung concentrations. Regarding ceftazidime avibactam, that is a cephalosporin beta-lactamase inhibitor combinations approved by the FDA for treatment of nosocomial pneumonia, that is as per the REPROVE trial. It is came as in 2018 in Lancet. And ceftolazone tazobactam, a second cephalosporin beta-lactamase inhibitor combinations, has been approved for the treatment of VAV. It is as per the ASPECT-NP trial. It has came in 2019 Lancet. Now, for more newer agents like cefepime, it is a novel cephalosporin with activity against some carbapenem resistant gram-negative bacilli, has also been approved for HAV and VAV treatment based on the randomized trial demonstrating non-inferiority to the high dose of extended infusions meropenem. So it has came in 2021, that is cefepime. And another is imipenem celestine relibactam, that combines the carbapenem imipenem celestines with the beta-lactamase inhibitor, that is relibactam. The combination restores the imipenem's activity against some carbapenem resistant enterobacteriaceae and the pseudomonas isolates. It was approved for the treatment of hospital-acquired pneumonia. Meropenem and verorbactam has been approved for the treatment of nosocomial pneumonia in Europe, but not in the United States. In the United States, it is only approved for the treatment of complicated urinary tract infections. Now for Legionella, patients who have compromised immune systems, diabetes mellitus, renal disease, structural lung disease, or have been recently treated with glucocorticoids may require coverage for Legionella species with azithromycin or fluoroquinolones. Anaerobes, patients who have aspirated or had a recent abdominal surgery may require coverage for anaerobes. Clindamycin, beta-lactamase inhibitors, or a carbapenems, they are sufficiently give anaerobe coverages. In general, however, anaerobes are rarely implicated in VAV, and some retrospective analysis suggests little difference in outcome in patients with aspiration pneumonitis treated with or without anaerobic coverage. So the prognosis, despite high mortality rates in hospital-acquired pneumonia patients, the mortality attributable to infections is difficult to guess. Many studies have found that HAV is associated with significant increased risk of death. However, many of these critical ill patients die from their underlying disease and not from pneumonia. For a crude, all cause of mortality associated with VAV has ranged from 20 to 50% in different studies. So, a comprehensive approach is therefore necessary to contain VAV. Thank you.
Very comprehensive. পুরো বইটাইও আমাদের থেকে ছেড়ে দিয়েছি তাই না? There's nothing left to say. Very excellent. রিসার্চ একটু সিম্পলিফাই করে যদি 10টা লাইনে আমাদের সবাইকে বলতে হয় তাহলে কি বলবো? What are the highlights, key points?
Now, first one things that I put like.
So, this is like not a, what I'm saying is not that I'm trying to tell you more about VAP. I'm trying to tell you more about presentation. Okay. So, যে কোনো জিনিস বলবেন কেন আমরা ওটা মাথামাথি করছি, why is VAP important? ঠিক আছে, VAP is important because it increases length of stay in hospitals, length of stay in ICUs, it increases duration of ventilation, it increases mortality, and it increases cost. Okay, so we are worried about that. Rapid prevalence, incidence, VAP is a common, relatively common problem. Patients, if you have a lot of ventilated patients, you will have a lot of that. So it occupies a lot of sort of our thinking time and working time. VAP. So it is important to prevent. Prevention is strategically bullied. So we understand there is a lot of overlap between the fast track and the ventilator bundle and the sepsis bundle, but a lot of it is geared towards prevention of VAP. Involve the nurses. They have an important role. Rush option and packet. তুমি হাত ধুয়ে তুলে ওরা যদি না ধর তাহলে গন্ডগোল হবে। ইনকিউবেশনের সময়ও খেয়াল রাখতে হবে। Though it is not a sterile procedure, but it is an aseptic procedure. Diagnosis is fraught with difficulty. আমরা জানি যে কোনো ইলেকট্রিক কোয়ালিটি মানে যে তিনটে জিনিস যে একটা চেস্ট সেকশনে কিছু একটা থাকতে হবে, একটা ইনফেকশনের কিছু ফিচার্স থাকতে হবে। ইনফেকশনের ফিচার্স মানে জ্বর, কাউন্ট, sputum purulence, etc. Cultures আমরা জানি যে there is a problem. And in the best situations, cultures will not be positive more than half the patient. And community acquired pneumonia থেকে এটা আরো difficult because a lot of the time this is polymicrobial. একাধিক bugs এখানে থাকে। There is an entity we briefly একটা জায়গায় কাজ করেছিল VAT, Ventilator associated bronchitis or bronchitis. So that is whether VAT is treatable or should be treated or how it is important. Is it just a precursor of VAT or is it an entity? কারণ আমরা যখন যে স্যাম্পলগুলো যে ইন্ডিভিজুয়াল অ্যাসপিরেট পাঠাচ্ছি মাঝে মাঝে পাঠাচ্ছি ধরো ইনকিউবেশনের সময় একটা পাঠালে তারপরে এভরি 48 72 আওয়ার্স হোয়াটএভার তুমি একটা সার্ভেইলেন্স তোমার তো একটা ডেটা ব্যাংক তৈরি করা দরকার, তো সব জায়গায় পাঠাতে থাকে। So whether that requires treatment or not. So once you have diagnosed, because we know shock pattern, job hote pare na hote pare, count আমরা জানি কম হতে পারে বেশি হতে পারে, sputum purulence is like very difficult to just yellow আছে না তুমি আর 25 neutrophils and then আছে কিনা জানি কেউ তাকে দেখে না ওদিকে, culture is also not. So a combination of things will make you think that this is a VAP. Once you diagnose VAP, what is important is the microbiology that you were thinking for CAP has shifted. VAP বলে আমরা আরো একটু difficult bugs এর কথা ভাবছি। Just like CAP, the next thing is how well or how unwell the patient is. ঠিক আছে, if the patient is unwell, তাহলে তোমাকে ভালো করে কভারেজ দিয়ে দিতে হবে। Pseudomonas কভারেজের কথা ভাবতে হবে, drug resistance কভারেজও ভাবতে হবে, MRSA কভারেজও ভাবতে হবে। If the patient is relatively well, then you can have a relatively simpler choice of antibiotic. It is best to have a protocol. And also you can try and rotate antibiotics. মানে 6 মাস একটাকে আমি রাখলাম, আর পরে 6 মাস একটা অন্যকে রাখলাম, so things might shift a little bit. Then you wait for the response in 48 hours. If the patient is okay, getting better, culture to আসবে 50% আসতে পারে, নাও আসতে পারে, then you take your decision. If there is worsening, hemodynamic worsening, gas exchange worsening, you're constantly looking for other pathologies, then you have to escalate antibiotics. If the patient is getting better and you have got some microbiology, then you have a good opportunity to de-escalate. If your patient is getting better and you have not got any microbiology, then things are a little bit difficult. যে কিরকম কতটা কি de-escalate করবে। Duration of antibiotic তুমি বলেছো, levofloxacin monotherapy আমি জানি না আমাদের দেশে, কারণ আমাদের দেশে There's a lot of GI infections, there's that in the community. A lot of people take a lot of quinolones. Videshe tumi quinolone prescription chhada pabe na. So there is a gatekeeping mechanism also. So the community থেকে patient আসে ICU তে, there will be very few who would have had previous quinolone in the last 90 days. কিন্তু আমাদের এখানে সেটা অনেকটা বিষয়। So using monotherapy quinolones, I would be a little bit cautious. আরেকটা আগে যেটা ছিল আমাদের pseudomonas diagnosis হলে we would normally give dual cover, কিন্তু সেটা the patient is reasonably okay, you can use single drug for pseudomonas. Durational therapy তুমি বলেই দিয়েছো, mortality etc. we've discussed regardless of the product. I think that is it. We've covered extensively. A lot of these antibiotics are not available to us, but we should have a protocol and we should have a surveillance mechanism. And if our incubation is showing the sample pata hobe, every ventilated patient is every 72 hours or something pata. একটা জিনিস আমি বুঝতে পারি যে আমরা say suppose you are spending 10 to 12 hours in the hospital every day. তো গত 15 দিনে যদি আমি ইনজেক্ট করি তাহলে তুমি 7 দিন হাসপাতালে থেকে ধরে নিতে পারি। এবারে so if one of us gets pneumonia at home, what will it be called? Hospital acquired or community acquired? Healthcare associated. Right? That is something that bothers me. What do you think?
Consider as hospital acquired.
Consider.
Because if space available out of 50 days in the hospital, it is a liquid source.
Yeah, so we get healthcare associated pneumonia like that. Whatever I say, somebody has had close contact with a healthcare facility in the last 30 days. That is generally what they use. আর ওটা ইভলভ করা হয়েছে ওই যারা ডেকেয়ার ডায়ালিসিস আসে, ডেকেয়ার কিমো আসে, ডেকেয়ার হেমাটোলজিতে থ্যালাসেমিয়া আসে, ব্লাড নিতে আসে। I suspect that could also apply to doctors, nurses, and some of the hospital staff. So সেটা একটা খেয়াল রাখা দরকার। But
Satish, with respect to what antibiotics you really will give to somebody who perhaps comes into hospital, the standard general tip tests with whatever, either doxy or with azithromycin or clarithromycin, that stays. It is only after you perhaps have had a run on that and still having an ill patient and thinking now that perhaps he's been complicated with WAP or HAP or whatever you want to call it. That's the time you think of changing the antibiotic.
see, what you have described now is somebody who's come in with a pneumonia.
Yeah, you said the doctor.
No, you just think about.
हम लोग ही आएंगे तो हम तो वही दवाई देंगे जो आप कम्युनिटी एक्वायर्ड निमोनिया दे रहे हैं।
This is what I'm wondering. Maybe that we should all on one day, যত ICU staff আছে সবার একটা swab job করে পাঠিয়ে we should get some information. You know what I mean? So this is something that's been bothering me. I'm not. I'm telling you, it's just fully nishish power. I'm sure we're not the first people thinking about it. But I'm talking about as a normal person. Say comes in with a community-acquired pneumonia and is in the ward, gets worse, lands up in ICU, gets ventilated, and then 3, 4, 5 days down the line, he might also develop further ventilator-associated pneumonia. That's because somebody comes on the ward, we do tend to overuse or overhit with the antibiotics, but they would not get piptazo in England as a first line for community-acquired pneumonia getting to the hospital. So then if they think that they're getting a WAP or a HAP, they would then
But we are using pictures only to begin.
yeah, but not necessarily the right thing to do, but that is perhaps we try to, in the absence of good community data and in the absence of enforcement of guidelines, we do and get away with it, but yeah, not necessarily the best practice. Yeah, Augmentin or Ceftriaxone and the macrolide, individual coverage. So that can be a macrolide. It's like be better perhaps. Doxycycline is an alternative, and quinolones are alternative. If you use quinolones, make sure you look at the pre-quinolone ECG and then repeat ECG.
Sir, the problem actually what we face mainly is whenever the patient is presenting with a pneumonia or a suspected, community acquired, the most of the time they will present and they have already consumed 2-3 antibiotics
Yeah.
outside.
Yeah,
That is the real challenge.
you're absolutely right. The patient এর 4 দিনে 4 রকম অ্যান্টিবায়োটিক পেয়েছে সেরকম হয়. Yeah. I mean, you see, there is no good answer to a bad situation.
Yes.
একটা হয়, I think if we have some sort of ওটাকে তুমি এক স্টেপ উপরে মানে that is perhaps one of the reasons
Why we
have.
And it also covers the urinary tract infection.
মানে we are now being pure saying that we
Yeah.
have a diagnosis. So suppose বাইরে থেকে হাসপাতালে suppose 3 দিন মেরোপেনেম পেয়েছে অনেকে আছে quack cry দিয়ে দিচ্ছে. So then what do? Do you de-escalate on day one? If the patient is sick, no, I would continue. But that is like I'm sharing a practical practice rather than giving you a recommendation.
Plus, sir, one more point is that in this hospital, especially I am talking, here actually we see a lot of immunocompromised patients because the cancer patient load is too high.
See, that is perhaps calls for a separate talk. We have not covered that, but yes, immunocompromise is a separate animal altogether. Yeah, I mean, and you see, antibiotic restriction community যদি ভালো থাকে তাহলে we can be more sensitive. It is very difficult to মানে পাকে কতগুলো বলা easy, is very difficult. Even people are having all sorts of things out in the community, আর তুমি বলবে যে আমি অগমেন্টেড দিয়ে সব শুরু করব, এটা খুব difficult হয়ে যায়. Good, excellent. তবে আমাদের এই preventive strategies গুলো যাতে আমরা একটু স্ট্রং হই আর সেটা যেটা বলবো যে আমরা যতটা সময় পেশেন্টের কাছে থাকি নার্সরা তার থেকে বেশি থাকে ওয়ার্ড বয়রাও থাকে সো দে শুড অলসো বি ইনভলভ আর
এই লিস্টে বলা হয়েছে বলেছো প্রিভেন্টিভ সাইন্সে এভিডেন্স বেস অনুযায়ী কোনগুলো আমরা ফলো করি
স্টেরয়েড বেসগুলো খুব ভালো করে
These things are recommended. That's
I call it
see the biggest thing is every patient requiring ventilation hospital আসাটা তো তুমি প্রিভেন্ট করতে পারছো. So if there are patients who mild illness can be treated at home, treat them at home. So that is one. Second is if they require intubation ventilation, or they require ventilation, think about NIV. Can I get away with NIV? Our common sense, so যেটা বললাম যে aseptic intubation, etc. If they're going to require, if it's a diazepam overdose, you can use any tube. Somebody's going to require prolonged ventilation, you use a second supraglottic suction in the rota. Chlorhexidine has good evidence. Head up is good. Use of again যেরকম sedation paralysis use হতো এখন use হয় না. Yeah, so that is important. Daily waking up strategy is actually very important. And the secondary things, somebody's got good nutrition, somebody's got good diabetes control, somebody's got more reasonable antibiotics, they will be less likely to have these other problems. And think about what is the next Monday when do you start thinking about weaning a patient? The time you intubate. You should have a rough plan. This is going to be my next few days at so you spend the least amount. Every day increases the risk of many folds actually. Inline section data আছে ওরা বলছে যে it reduces the incidence of pneumonia but there was no difference in the mortality. So like there was a time যখন মানে আমাদের ICU চার্জ ছিল বোধহয় 3000 টাকা আর inline section devices 1200 না 1500 টাকা. So the question was যে আমরা ইউজ করব কি করব না. But it is a nice thing you can use it. মানে intuitively মনে হয় যে কিছুটা তো protection থাকে. But we were not using it at that time because the cost was a big chunk of that. And the data, certainly I looked at it that time, it showed that it does decrease pneumonia, but there was no change in the outcome.
আরেকটা প্রবলেম আছে স্যার যেটা যারা ফিল্ডে রেগুলার করে তাদের সেটা হচ্ছে প্রেশারটা অনেক কম ক্ষেত্রে ওইটা একটা খুব বড় অসুবিধা
And also like if you got a sick patient on high pressures and peak etc. তখন এগুলো যত তুমি করবে তত ঝামেলা
প্লাস ঠিক করে ক্লোজ না করলে
so you got to be familiar with what you are using, and you don't actually the nurses. You have to remember, nurse to patient ratio in a ventilated patient, abroad it's going to be at least sorry, 1.5 nurses to patient. If you are in the US, then the ventilation bit is looked after not by the nurse, but there's a separate respiratory therapist. So, অনেক লোক মিলে দেখছে, so সেটা খেয়াল রাখতে হবে। It is better, it is easier to maintain all this hand hygiene and no touch and সবকিছু খুঁটিনাটি দেখা if there is lots of people looking after the patient. আর একটা নার্স যদি তিনটে পেশেন্টকে একটু দেখছে, তাহলে একটু রিমুভ হয়ে যাবে।
যদি কি ব্যবহার করা হয় সিলেক্টিভ ওরাল
It this was people have tried it, but you see now we are going into less use of antibiotics, etc. Complex major abdominal surgery there are some units they use it and that has improved their mortalities. But from the point of view of pneumonia, it is again that same thing that it reduces pneumonia but doesn't reduce outbursts.
What are the erythromycin?
Erythromycin is for GI motility.
SDD জন্য selective decontamination.
Decontamination কিন্তু ওরা আরো অনেক বেশি ইউজ করে। I thought you were meaning erythromycin to increase GI as a prokinetic.
No, as decontamination.
I don't know about erythromycin specifically, but people have used a lot of it's like neomycin, metronidazole type combinations, but not recommended as a regular practice at all.
Sir, regarding aminoglycosides, the data we have found that is not very much used in case of renal septic patient. Can we give that medication sort of?
Yeah, you see, again, I'd like to handicap that. See, you should have facility to do aminoglycoside levels. Yeah? And you then either reduce the dose or you increase the interval. So it is not that you cannot give it, but you have to make this thing. And how do you do it? In a blindly korata thing, if you have some levels, then it is helpful. Unfortunately, that level is power that.
Actually, studies are মানে স্টাডিজে দেখা গেছে যে কম্পেয়ার করে যদি অ্যামাইনোগ্লাইকোসাইড উইথ যদি কোনো কার্বাপেনাম ইয়েতে দেওয়া যায়, তার সঙ্গে যদি মনে করুন আমি পিপটাজের সঙ্গে অ্যামাইনোগ্লাইকোসাইড বা পিপটাজের সঙ্গে এটা সুযোগ হয়ে যাবে, সেখানে কিন্তু দেখা গেছে অ্যামাইনোগ্লাইকোসাইডের গ্রুপের যেটা মর্টালিটি এই মর্টালিটি মানে বেনিফিটটা বেশি।
I mean, it is a good antibiotic. It is active against a lot of the gram negatives. It is also active against some gram positives. It has MSSA against it, but not work against MRSA. That's a simple, safe antibiotic. It's only antibiotics, and it is pretty good. I mean, as long as remember, it's not really if you waste that creatinine 1.4, how do you interpret it? So you get a that the GFR is already perhaps 40 or 30. So that you can't use a standard dose. So that is why levels are important. Levels but that is how they use it.
Plus, do you think what a bond of product is actually?
Actually, the idea is recommendation monotherapy aminoglycoside is not to use.
Why? Because it's a bacteriostatic. Glycosides are bacteriostatics. But দেখবেন কলেজে অনেকে UTI অনেকে I remember when I was a medical student, my father got a urinary tract infection. I talked to my hospital brother and we gave gentamicin বাড়িতে আনেন প্রতিদিন তো creatinine দেখা হয় so but you can't do that now.
স্যার এখনো চলে বাইরে কমিউনিটিতে খারাপ হয়েছে তার জন্য দুটিতে অ্যাডমিশন বাড়িতে পেয়ে গেছে।
Quite do it because I'm familiar with it. It's cheap,
But it's value for money.
It's value. It's cheap.
It's unbelievable that it is available at such a low rate.
Quinolones, you see, when quinolones came, it was perhaps the first oral antibiotic against gram-negative bugs. By quinolone, গ্রাম নেগেটিভ এগেইনস্টে ভালো মানে এই যে ক্যাফলোস্পোরিন যেগুলো এসেছিল তখন থেকে বা যেটা ওরাল ছিল সেটা was মানে ফার্স্ট মানে কি বলা যায় it's the first generation. There were more gram positive. They Sporidex, Sporidex, Cefalexin. That was the first one that came. A Cefixin techniques গুলো পরে এসেছে। Ciproca was the first one to come. It became a great hit, especially the cystic fibrosis patients. And তাদের organized হয়ে যেত with staff and with pseudomonas. And তাদের ওই ভর্তি হয়ে এখানে ইন্টারভিউস নিতে হতো, they got put on oral Cipro. আর আমাদের এখানে এন্টেরিকে and then the লোকে গ্যাস্ট্রাইটিসে use করে এখন তো there's a lot of quinolone resistance in certainly our setting.
So there is a renal dysfunction whether to use it or not.
Yeah.
The answer is not contraindicated.
Yeah.
The problem is that those are just
If you have a better alternative, better alternative, you use it, but you can use it.
And as a synergistic means
That is correct. But you have to have levels, and you have to modify the dose or the interval appropriately.
GFR and creatine clearance.
exactly. নোমোগ্রাম থাকতো মানে একটু অনেকদিন আগের কথা বলছি এখন বডি চিকানো থাকতো আর ওই সন্ধ্যাবেলা সিস্টেমদের ফোন আসতো যে সব লেভেলস গুলো চলে এসেছে একটু গিয়ে লেভেল দেখে নোমোগ্রাম দেখে ড্রাগ চার্টের ডোজ গুলো লিখে দিতে হবে আর নেক্সট কল করতে হবে that was the job. We don't do that. I mean, there are drugs, digoxin, glycoside, theophylline, which we never used without doing drug works.
এটা আপনি কত বছর আগে কথা বলছেন?
Jurassic. No, what it says is that they were doing all that at that time. See, all that was happening at that time. I'm talking about when I came back here in 1999. So it's 20 years, but he's still not.
Regarding aminoglycosides, যেমন cephalosporin বা penicillins are duration dependent, MIC dependent. That's why the question of infusion comes.
Yeah.
Aminoglycosides take concentration.
Yeah. So
You can go for bolus.
yeah, I mean, 500 BD is standard dose, essentially 15 milligrams per kilo. 500 is split further, but you can use it as a single dose.
And that to bolus.
Excellent.
So, number 2.
Comprehensive.